Hello, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly webinar series and thank you for participating. Before we begin, I would like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. Ashley has added a chat waterfall. We ask that you put your name, your organization, and also our question for today is on a scale of 1 to 5, to what extent are you comfortable managing patients with active ketamine use? 1 being not at all the way up to 5, I'm a master. So we look forward to seeing your responses. Today's session is being recorded. The session recording and a PDF of the presentation slides will be added to NAHU's website as a resource later today or tomorrow. You will receive this information in the post-webinar email that will be sent out through Zoom tomorrow. You can also visit the resource page on the website to find this resource and view the past sessions. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. If there is time and you would like to ask your question live, please raise your virtual hand and I will open your line to speak. So just some background on NAHUD. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the AETCs. Established in 2010, NAHUD supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, also known as ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery of opioid use disorders, and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN events or trainings, learn about ORN work groups addressing health disparities, and more. We value and welcome your feedback on today's webinar. We will include a link to the evaluation towards the end of the session. It will also be included in the post-webinar email that you'll receive tomorrow. If you are a phone participant, please send me an email with your name and the phone number you use to participate on today's call so that I can send you the evaluation link. You will have 2 weeks to complete the evaluation. Once the survey is closed, we are unable to reopen it. So please complete the survey during that time. If you have any questions, once again, please feel free to reach out to me. If you are requesting CE credit or a certificate of attendance, you will need to complete the evaluation. To receive contact hours for participating in the continuing education program, you will need to register, join this webinar, attend at least 60% of the presentation, and complete and submit the electronic evaluation. If you are in a group today, we ask that if you're going to submit your evaluation, as we would love your feedback, you will need to sign onto a computer and so that it can register that you are attending, and that way we can mark that you attended for the required time to receive your CE and evaluation. Also, we do welcome your feedback in that we will be sharing it with our speaker today. So again, we do want you to complete it. You will receive your requested certificate within 3 weeks of submission of the evaluation. So with that said, I have the great pleasure of introducing Dr. Alexander Thomas, who is an assistant professor of clinical psychiatry at the Indiana University School of Medicine, IU, where he is the program director for the Addiction Psychiatry Fellowship. He is focused on expanding the treatment of co-occurring substance use and psychiatric disorders. He has expanded services at the Sandra Escanzi Mental Health Center and IU Health Neuroscience Center, directs a clinic at IU Health Eagle Highlands and directs a co-located integrated clinic with IU Health Gastroenterology and Hepatology. He is active in medical education and serves as the course director for the addiction psychiatry didactics for IU School of Medicine. His research interest is exploring glutamatergic medications for the treatment of substance use disorders. Dr. Thomas, you can correct any of those words that I may have said wrong, but again, we welcome you, and I'm going to hand it over to you.
Thank you so much. Let me get my slides going. Let me see. Thank you everyone for coming today. This is a topic that I'm very passionate about. We have a lot to go through today, but I want to make sure that I leave time for questions at the very end. I do have a case, and we'll see if we have time to go through that case in detail. But today we'll be talking about ketamine and ketamine use disorder. So, disclosures. I have no conflicts of interest. However, all of this is off-label for the use of, or I will be discussing off-label uses of ketamine. Just kind of some objectives today. I'd like you to be able to identify ketamine intoxication, describe the acute and chronic complications of ketamine use, be familiar with the treatment of ketamine use disorder, and then there's another side to ketamine, and I would like you to at least be familiar with ketamine as a treatment for substance use disorders. The outline for today, we'll go into the background of ketamine, the risks of using ketamine, the treatment of using ketamine, how it relates to other substance use disorders. I do want to go into considerations specifically for people living with HIV, and then we'll see if we have time for a case at the very end. So the background, how did ketamine use disorder begin? Ketamine was originally synthesized in 1962 as a replacement for PCP. PCP turned out to be a great anesthetic, but believe it or not, the side effect profile is pretty bad, and when people woke up out of general anesthesia, they tended to be pretty profoundly psychotic. That being said, ketamine is synthesized, and they find that it has an excellent safety profile as a general anesthetic because it doesn't cause respiratory suppression or people don't stop breathing while they're under general anesthesia with ketamine. As a result, the World Health Organization labeled it an essential medicine because that means you don't have to put someone on a ventilator despite giving them general anesthesia. So, in places without access to electricity or supplemental oxygen, you can still have a general anesthetic. In society, though, synthesized in 1962, it did not take long. The first reports of non-medical ketamine use were in the 1960s. But it really didn't hit the scene or become big until the 1990s. And initially, it was in Europe at quote-unquote raves, and it was introduced as an adulterant to ecstasy or MDMA. This is relevant because ketamine is often used with other substances, and even from the very beginning, ketamine was used with other substances. When we talk about globally, where is ketamine the biggest problem? It seems to be Southeast Asia. Interestingly enough, historically, in the 2010s, it was the most commonly misused drug in Hong Kong, as an example. A lot of the data that I'll be talking about today actually comes out of Southeast Asia when we're talking about epidemiology, and treatment comes out of both Europe and the United States. All of that being said, though, it is progressively becoming more popular in the US, and the rates of ketamine use, non-medicinal as well as medicinal ketamine use, are going up pretty steadily. In terms of mental health treatment, because I do want to talk about how it can treat substance use disorders, in the 1970s, people began experimenting with ketamine to treat mental illness. This translated to formal investigation in the 1990s. Recently, it's exploded. Past 20 to 25 years, they've looked at ketamine for the treatment of nearly every mental illness. And this kind of culminated in 2019 when Spravato, S-ketamine, was approved for treatment-resistant depression. Now, ketamine, will go into what it is more shortly, but it has an S enantiomer and an R enantiomer. S-ketamine is just the S part of it. But now the R enantiomer is actually getting some attention for the treatment of mental illness as well. Specifically, when you're treating mental illness, often ketamine is used to augment psychotherapy. They're used together as opposed to just ketamine within itself. And it's found to not just be additive, but rather synergistic. So this is commonly called ketamine-assisted psychotherapy. Interestingly, it works in both an individual and group setting. And I smile because it is just fascinating to me to sit around or to think about a group of people sitting around, all intoxicated on ketamine, talking in group therapy, and that is actually synergistically effective. And then when you're talking about ketamine administration for the treatment of depression, when you combine it with cognitive behavioral therapy, you actually prolong the benefits that ketamine gets initially. When you're looking at psychotherapy in particular, it's worth noting that psychedelic dosing for the treatment of mental illness seems to be more effective. And we'll go into the different dosings, but in the research, this has been termed the mystical experience associated with taking ketamine. So that's kind of how ketamine came onto the scene. How does it work? The big thing to know is it is an NMDA receptor antagonist, but it also blocks nicotinic acetylcholine ions. It increases dopaminergic and noradrenergic activity, and it is a weak agonist of the delta mu opioid receptor. So it does activate the opioid receptors. Now that's fine and dandy, and those are just words, though. What does it actually do? So it increases neuroplasticity. And what that means is you're increasing the growth and the connection of neurons in the brain by administering ketamine. It disrupts functional networks. So the brain, we think of the brain in all these regions, but then there are networks on top of just individual regions, and all these networks have to talk to one another. And during active substance use or during other mental illnesses, these networks aren't really talking to each other in the right way. And ketamine breaks those connections temporarily, almost serving as a magical reset button. It has very rapid antidepressant effects. Intravenous ketamine arguably is the fastest antidepressant we have access to. Then there's the reconsolidation of memories. So when you do something, you form a memory of it. It is then consolidated. But when we think of memories, they come forward. And actually, memories are not fixed. You can alter memories. And then after you bring it forward, it is then reconsolidated, put back in storage. Well, ketamine can block the reconsolidation of a memory. So if you bring out a memory, you then have an opportunity to change it, and you have the opportunity to block it from going back into storage. This becomes relevant for the treatment of substance use disorders when we're talking about cue-induced cravings. You can actually significantly reduce or eliminate them by blocking the memories of using in a certain place or using with a certain group of people. And then there are the psychedelic effects from using ketamine. We need to talk about how ketamine is used. So medically, primarily intravenous. I've thought long and hard about why do we use it IV, because IV has a lot of monitoring and it's intensive and so on and so forth, but it gives you a lot of control. You know the exact amount that's going into someone's system, complete bioavailability, so you know 100% of it is in their system, and you can control how fast it's going in, so on and so forth. And I think that's why IV is the most popular in medicine. The next one would be intranasal. This is the FDA approved treatment, S-ketamine. It's administered intranasally, although ketamine you can do intranasal ketamine, then intramuscular, because intravenous requires, I don't know, a lot of logistics, quite frankly. Some people have started doing intramuscular. It has a very high bioavailability, so not 100% getting into your system, but arguably high 90s. And then the least common medicinally is oral. That's because when you take ketamine orally, it's absorbed in your gastrointestinal tract. But once it's absorbed in the gastrointestinal tract, it all goes to the liver. And the liver will process that ketamine into its metabolites. And you actually get a different effect if you're using ketamine versus the stuff that ketamine is transformed into. And so it works differently if you take it orally. Now there's the recreational use of ketamine. Ketamine primarily comes in a powder, and so you snort it by and large. Less commonly, but still a thing, people will use ketamine IV or IM. Rarely, for the same reasons I just talked about, do people use ketamine orally. The metabolites, or what ketamine is processed into, makes you sedated, so it makes you tired, but it doesn't really give you the psychedelic effects. And so if you're using it at a rave, for instance, you're probably looking for the psychedelic effects as opposed to just, I'm going to take this orally and get tired from it. Let's talk dosing and intoxication. There are four doses associated with ketamine. First, we have the low below the psychedelic effects. This has been termed K-land. There's kind of like a sense of oneness with other people and an empathogenic experience. You up the dose a little bit to the medium doses. We're now at psychedelic dosing. People pretty consistently describe this as like a dissociative effect or an out of body experience. And this has been termed a K hole. Then you go even higher, and we get to high doses of psychedelic dosing. And the research describes this as dissolution of boundaries between reality and self. Commonly, people refer to this as the near death experience associated with ketamine use. You're still in a K hole. The fourth is if you go even above that, it is now a general anesthetic. The reported effects of using ketamine, melting into the surroundings is commonly reported. Like you feel like your sense of where your body starts and ends fades, and so you become one with your surroundings. Visual hallucinations are very common, psychedelic dosing. It amuses me that giggliness is very commonly reported. And then as you increase the dose, dissociation becomes more and more significant. And you can become completely detached from reality when it comes to dissociating from ketamine. But what else does it do, right? So it does have antidepressant effects, admittedly, and it does reduce suicidal ideation, particularly when used intravenously. On top of that, though, it causes delirium. It makes people have false beliefs or delusions, and just people become overtly confused when they use ketamine. And when talking about these delusions and visual hallucinations and things of that sort, people almost seem psychotic. It's very psychosis-like when patients are intoxicated with ketamine, and it's been so psychosis-like that it's been used as a model for schizophrenia. So they took healthy people, gave them ketamine, which makes them look like they have schizophrenia, and then they were testing new agents on them to see if the psychosis resolved, and then that would actually translate to a treatment for schizophrenia. So it's been used in pharmacological research. The withdrawal from ketamine is a lot more muddy, let's say. It's pretty clear that you get cravings when you're withdrawing from ketamine, but there's a debate, a decent debate, about is anything else consistently present? Sometimes people are depressed. Sometimes people are anxious. From a physical standpoint, you can see shaking, sweating, and the heart rate going up. So people feel palpitations. They feel like their heart is racing. but it's unclear if any of this is consistent. It's just kind of a syndrome that you're looking for. The one thing that stands consistent is people will crave ketamine during the withdrawal period. Okay, let's talk about the risks associated with using ketamine. We're going to break this down into the short term or acute and the long term chronic. So, acute use, we have to talk about overdose. So, the primary way you use ketamine is by snorting it. And so, overdosing on ketamine is actually incredibly challenging. Just ketamine, let me be clear. When you're just using ketamine, it is incredibly difficult to accomplish. You need 25 times the usual dose. But when you think about it, okay, so I am snorting ketamine and I get to a point where I am completely detached from reality, but somehow I am still able, despite being discoordinated, not knowing where my body is, to continue snorting ketamine. You reach a point where you're at a general anesthetic and you are no longer capable of taking in more ketamine. And when you reach the general anesthetic dose, there isn't respiratory suppression when you initially get there, and the coughing and swallowing reflexes are maintained. Now, if once you get to general anesthetic dose, you somehow are able to keep taking ketamine, sure. But because the general anesthetic dose provides a ceiling effect, overdosing on just ketamine alone is pretty challenging. On the flip side, there are a lot of heart or cardiovascular risks. So, short term, ketamine increases your blood pressure, and it can increase your blood pressure pretty significantly. It increases your heart rate, so tachycardia. The other thing is, as I said before, ketamine was introduced when it was adulterated with MDMA. Ketamine is commonly used with methamphetamine and cocaine. And so when you think about ketamine increasing blood pressure and heart rate, and it's commonly taken with methamphetamine or cocaine, you can see dramatic increases in blood pressure and heart rate. There is some pretty significant cognitive impairment associated with using ketamine. And I listed the four specific kinds or the three specific kinds of memory and verbal learning that tend to be impaired. So there's working memory. And so this is like I am literally working on a project, but then someone over here says something, so my attention turns. I'm able to address this, but my mind is holding on to what I was initially doing. And then I return to it because I was able to remember what I was doing. That is gone. That is gone. Working memory is significantly impaired. And so task shifting appears impaired. Then there's episodic memory, personal experiences or events. People that are actively intoxicated on ketamine, they may genuinely not be able to remember their own history. Then there's verbal learning, and this is just taking in verbal information. So someone talking to them about, hey, you should do this, this is important, so on and so forth, or they're engaged in therapy while intoxicated on ketamine, like that's impaired. You cannot learn from someone talking to you while you're taking ketamine. And then spatial memory, just remembering where things are. And so I am familiar with this office. And so I could close my eyes and probably navigate it okay. I could find the door. Using ketamine, even in the short term, you lose that. Even in familiar places, you lose the ability to remember where things are in your surroundings. And that takes us to accidental death. So this is the highest source of mortality associated with short-term ketamine use. So you lose your sense of where you are based on using ketamine. You lose your ability to remember your surroundings while intoxicated with ketamine. And because it is an anesthetic, you can't feel if you're getting hurt. And so just people accidentally uh, have traumatic deaths, unfortunately. And so one of the main things for harm reduction is people intoxicated with ketamine should not be left alone. In addition to that, the person that's with them should be sober, and not intoxicated on anything, ideally, because when you leave them alone and they're left to their own devices, some tragedies really can happen. That is the short-term use. Let's talk chronic use. So now we're talking long term. And so you're using ketamine every day-ish on a long-term basis. There is ulcerative cystitis. So most people are familiar with a stomach ulcer. And this is a breakdown in the lining of the stomach. Ulcerative cystitis is a breakdown in the lining of the bladder. So you get ulcers in your bladder. Makes you urinate more frequently. It's painful to urinate, and you're also urinating blood from the ulcer. And this is relatively common with long-term use of ketamine. It doesn't just impact the bladder, though. It impacts your kidneys too. It makes them enlarge, hydronephrosis. It can make parts of them die, papillary necrosis, and then overt renal failure, or just straight up kidney failure has been documented as a result of long-term ketamine use. K cramps are also common. So this is crampy abdominal pain. And so it comes and goes. The thing is, when you're having cramps and crampy abdominal pain, you can use ketamine. Ketamine is an anesthetic after all. And so by using ketamine again, your abdominal pain actually goes away. And so you can see how this vicious cycle occurs. Ketamine use is causing episodic crampy abdominal pain, but ketamine makes it completely resolve. The belief among the community, my understanding is, they're inhaling ketamine, and if you swallow the postnasal drip, you get K cramps. That is wrong. That is not how that works. They do CTs, or they've imaged people, and there's cystic dilation of the bile ducts. All that means is your liver is getting damaged and there's fibrosis of the liver. That is what's causing your cramping abdominal pain. That is not from swallowing the postnasal drip. So it's just ketamine use in general that causes K cramps, regardless of the amount you're swallowing. Then there's the long-term psychological issues. Interestingly, there is increased depression. So we talked about how short-term or acutely, there are antidepressant effects. But when you transition to using ketamine every day, you actually see increased depression. So there's a reversal at some point. It is psychosis-like. People that are using ketamine every day look like they have schizophrenia. I said that it was a pharmacologic model for schizophrenia, and so they just look like they have schizophrenia. Associated with that, they have delusions, or they'll be paranoid, or be having hallucinations. And then there's dissociation. Part of the out-of-body experience, you can just continue to have dissociative episodes with long-term use of ketamine. Neurologic. There are physical changes that happen in the brain with long-term ketamine use, specifically in the temporal lobe. Your temporal lobe is where all the memory stuff is, and so it makes sense that that's where a lot of the changes would be. And I guess I go like this because temporal lobe right by your temples. Then there's upregulation of dopamine receptors, and the changes in the temporal lobe, they're what leads to the cognitive impairment, both short-term and long-term. In particular, remembering stuff about yourself long-term is just impaired, and it can be dramatically impaired. The good news is the cognitive impairment seems to be reversible when you stop ketamine use. And then part of the talk today, ketamine use disorder. So ketamine increases the release and it inhibits the uptake of dopamine in the nucleus accumbens. That is how things become addictive. The reward center of the brain gets blasted with dopamine. It does interact with opioid receptors, promoting rewarding properties. It has a short half-life, and so you have to use frequently to maintain the spikes. And then there's tachyphylaxis. What this means is you build a very big tolerance very quickly. And so you use it once. Well, next time you might have to use twice that amount. And next time you might have to use three times that amount. And so, because of the quick tolerance that develops, the amount of ketamine that daily users use is really high. And they're using multiple times a day because the half-life is so short. When people develop ketamine use disorder, that is strongly associated with lower education, unemployment, and increased healthcare utilization, in particular for the bladder complications, the ulcerative cystitis. How do you treat ketamine use disorder? So this is about managing the complications, short and long term, as well as the underlying cause, the substance use disorder itself. So if someone's intoxicated on ketamine, the research pretty robustly supports first generation antipsychotics, specifically Haldol, haloperidol, and benzos. If someone is withdrawing from ketamine, if they appear anxious and they're in a controlled environment, an option is to give them benzodiazepines. You can use other antipsychotics for withdrawal, olanzapine and haloperidol. It seems like propranolol and clonidine can be beneficial when you think about the anxiety as well as the cardiovascular effects. It seems to be symptomatic treatment that does more than nothing for the withdrawal. But let's talk the use disorder. So there is no standard treatment. Start there. No standard treatment. There is no beautiful clinical trial that I can point to be like, this is the best thing to do. But there is evidence for a variety of things. Lamotrigine changes the experience. A lot of people have heard of antabuse or disulfiram for alcohol. And this is you drink, and it provides a very negative experience associated with drinking. Lamotrigine to ketamine is antabuse to alcohol. It changes the experience to make it a very negative experience. Naltrexone can decrease cravings. Gabapentin and topiramate can also decrease cravings. And then there was a very interesting case report about the combination of paliperidone and bupropion improving the depressive symptoms as well as cravings for ketamine. Then there are the behavioral and cognitive interventions that really target the cravings and compulsive use. In terms of the complications, NSAIDs, anti-inflammatory stuff in general, is what you're going for, especially for the ulcerative cystitis. Anticholinergic medications can help with urinary frequency. Some people, because of their long-term ketamine use, have needed urinary diversion. You're literally diverting the urine away from the bladder, or a nephrectomy. There's been so much damage done to the kidney that they had to remove it. Ultimately, the way you treat the long-term complications of ketamine is by abstinence. If you stop using ketamine, a lot of, if not all, the long-term complications can at least partially reverse. Let's talk about ketamine in relationship to other substance use disorders. So a lot of it is really unknown, but polysubstance with ketamine use is the rule rather than the exception. There are historical factors to this, right? It was introduced as part of a combo drug, and it just seems that frustratingly for me, the research primarily focuses on the other stuff. It seems like the ketamine use is not the primary focus, as opposed to the cocaine and methamphetamine being the primary focus. That being said, when used medicinally or in a controlled environment medically, ketamine might actually treat other substance use disorders. And so there's this whole different side about like ketamine causes all these acute and chronic complications, and you can develop ketamine use disorder. But on the flip side, we might actually be able to treat other substance use disorders if ketamine is used correctly. Let's talk about opioid use disorders because opioid use disorder is a ginormous problem in the United States. So there's actually a theoretical prevention when ketamine is used. So for pain management, when you use ketamine as part of an operation, it shows that you decrease the amount of opioids people need associated with that operation. You can also use intravenous ketamine infusions for chronic pain management instead of long-term opioids. When it comes to outpatient prescriptions or outside the hospital stuff, if you give people ketamine in addition to their opioids, you actually reduce the amount that you're suppressing their breathing. It prevents the rebound sensitivity to pain or hyperalgesia, and you can actually lower the amount of opioids that they need for pain control. For opioid withdrawal, there's some really cool case series. So one of the big barriers to initiating buprenorphine in people using fentanyl, as you may be aware, is precipitating opioid withdrawal. Seems like ketamine might be a really cool option to treat this because in these case reports and case series, it is remarkable. The other thing is it can be used for very quick outpatient weans from opioid scripts. And then there are just anecdotal reports of people being like, I was using heroin, I was using fentanyl, and I used ketamine to treat my withdrawal. Very robustly, when there are studies done, it reduces withdrawal scores. Their cow scores go down when they get opioids or when they get ketamine. But let's talk about opioid use disorder specifically. So, for opioid use disorder, glutamatergic dysfunction, it just happens. And this is part of all substance use disorders. And ketamine kind of reverses the glutamatergic dysfunction by promoting neuroplasticity and by increasing the way that you can build new connections in the brain. It could be that you're facilitating learning, right? And so when you go into therapy or some sort of psychotherapy, you're trying to teach them something or you're trying to process something. Neuroplasticity might speed up that process. And then you're restoring imbalances in glutamatergic systems. And a lot of that has to do with way back when I said they're like functional networks that aren't talking to each other the right way. And ketamine breaks those connections. And then when it leaves, it's just this giant reset button. And that is restoring the glutamatergic imbalance. As a result, you actually decrease opioid cravings, you improve withdrawal. A lot of people with opioid use disorder have comorbid depression. And in the research, there's enhanced motivation for change, which I think is dramatic. So let's go into a couple of interesting studies or studies that I enjoy talking about. So Krupitsky and Grenko, they studied existential psychotherapy, and their question was, do we need psychedelic dosing or sub-psychedelic dosing of ketamine to treat opioid use disorder? Here's the specific treatment procedure. They prepped people with 10 hours of psychotherapy. The ketamine session lasted 1 to 2 hours, consistent with the duration of ketamine. They provided emotional support. And interestingly, there was individualized psychotherapy focused on, quote, personality problems, their words, not mine. And then after, and I do believe it was the day after, there were 5 hours of psychotherapy to talk about their experience during the ketamine session and kind of integrate what they learned during it into everyday life. And this worked. well. They talked to people about, hey, you got ketamine. How do you feel? And decreased craving scores. The rates of anhedonia or not caring about things within the context of depression went down. They found that people were less anxious. They were less depressed. I was really impressed. So they did MMPIs or like personality rating scales. People said that their internal locus of control increased. They felt like they had more control over their life. They consistently reported that they feel like they have more sense of purpose, increased spirituality, and their attitudes towards stopping substance use improved. What this translated to was a actual abstinence at 24 months. And they saw that if you had a psychedelic dose or one of the higher doses, the rate of abstinence was higher. The next question that they looked at was, well, we did it one time, right? We did psychedelic or sub-psychedelic one time. What if we do it three times? Is that even better? Is it dose related? Can we repeat this? They said everyone's getting the psychedelic dose. And they compared one session versus three, again, psychotherapy before and after. And the multiple session, they added on some addiction counseling before and after the second, third. And they found out there is a dose response relationship. Three sessions is better than one. Now, to be clear, the same improvements that I just talked about with the psychedelic dosing we're seeing across the board. At 1 year, half of the participants were not using opioids, which I think is tremendous. That means for a limited period of time, they interacted with medical providers three times over the course of 3 days each time. But that is a very time limited intervention, right? Like that is 9 days over the course of 2 to 3 months. And then 12 months out, half of them are not using any opioids. That's dramatic in my mind. It's not just opioid use disorder. I do want to go over some other substances, although this is not all inclusive. For alcohol use disorder, while aversive therapy is highly unethical, and this data actually comes out of Russia, is what it is. They found that when you add ketamine to that kind of therapy, you get 70% abstinence. And ketamine assisted psychotherapy, about 2/3 were abstinent at 12 months, as opposed to conventional psychotherapy, where we had 1 in 4. Relevant to us and much more modern standards, when they combined ketamine with motivational interviewing, 3 in 4 were abstinent at 6 months from alcohol, as opposed to using an active placebo, midazolam, trying to mimic ketamine as much as possible without it being ketamine, with motivational interviewing. And so they were able to triple the success rate when they used ketamine. For alcohol withdrawal, it seems like ketamine actually works really well. When benzos no longer control alcohol withdrawal, if you give someone ketamine, you decrease the rate that they need to go on a ventilator and you decrease the number of days that they're in ICU. What this means to me is ketamine is unique in that you might be able to treat people when they're withdrawing from alcohol and opioids simultaneously. Let's talk stimulants. I brought this up a bunch, ketamine, ketamine can treat cocaine. Cocaine use disorder and stimulant use disorder are pretty big problems, but when they combined it with mindfulness-based behavioral modification, they were able to get half abstinent at 2 weeks versus 1 in 10 at midazolam. And they said, okay, 2 weeks is fine. Let's look months out. Half turned into 44% abstinent at 6 months, compared with a whopping 0%. that were in this study that did not receive ketamine. But the cocaine use disorder literature, I think, is really cool because they tried ketamine without psychotherapy. They said, okay, well, it may enhance psychotherapy, and there's evidence for that, but there are logistical barriers to providing psychotherapy with every single patient every single time. What if we just infuse them with ketamine and see what happens? So, in non treatment seeking individuals, people that at the beginning of the study, if you were open to the idea of cutting out cocaine, you were not included, you were kicked out. So, these are non treatment seeking individuals, and they said, yes, I'll get ketamine. So, they infused them with ketamine, and then they looked at, all right, how much cocaine are you using? And they used about two-thirds less after a single infusion of ketamine. They said, wow, okay, so let's keep doing this. And so after three infusions, the people that were non-treatment seeking to begin with, some of them said, I think I'm ready to quit. And a month out from these three sessions, they were able to demonstrate that cue-induced craving, or things that reminded them of cocaine use, actually didn't induce the cravings anywhere near as bad anymore. They did look at this and they said, okay, ketamine does a bunch of stuff. What part of the ketamine experience is helping? And they were able to pretty much nail down it's the psychedelic effects, the mystical experience that seems to be so important for treating substance use disorders, as opposed to something like the dissociation that occurs when you use ketamine. There's a lot of stuff going on right now that I find very exciting. So, ongoing look into just ketamine assisted psychotherapy for a variety of things. People are finally doing pretty rigorous trials for substance use disorders plus depression or plus major depressive disorder. And I am hopeful that that will show ketamine is effective, remains to be seen, but I'm cautiously optimistic. But then there's tobacco, cannabis, and amphetamine type stimulants. There is emerging evidence that ketamine helps tobacco use disorder. Same thing with cannabis. There's emerging evidence that it can decrease cannabis use and increase the rate of abstinence for people with cannabis use disorder. Amphetamine type stimulants have been really tricky to study because when you think about ketamine causes psychosis, you probably don't want to use it in people with a history of psychosis. And so there's been a hesitation to study methamphetamine use disorder, but studies are ongoing. I just don't have the results yet. Okay, in the time we have left, we need to talk about considerations related to HIV. So if someone is using ketamine, that is associated with a higher rate of high risk sexual behavior across the board. When they look at, there's not a lot of studies examining just a general population base, but the ones that are consistently show it's associated with a higher rate of high risk sexual behavior. The ones that are looking at subpopulations do identify that it's associated with an increased risk of sexual transmission of HIV. And this risk is particularly high among men who have sex with men. And this is emerging evidence, and I don't think it's definitive yet, but it may decrease adherence to antiretroviral regimens if someone's actively using ketamine. Now, when you just look at men who have sex with men and you say, all right, let's look at the rates of ketamine, it turns out this subpopulation is more likely to use ketamine than the general population. And when you look at, okay, if they are men who have sex with men and living with HIV, that population is even more likely to actively be using ketamine. There are drug-drug interactions that I think people should be aware of. So ketamine is primarily metabolized by CYP2B6, 3A4, 2C9, yes, but no. 2B6 is the big one. These three meds inhibit 2D6. Ritonavir is notorious. And so you're increasing the amount of ketamine in someone's system and you're prolonging the effects of ketamine when they're on these particular medications. And then it's worth noting all protease inhibitors block CYP3A4. It's unclear at this point if that has clinically significant implications for someone that's recreationally using ketamine. But like we've been talking about, there's a flip side to this. There's an ongoing trial called the CARE trial, and it said, well, let's do ketamine assisted psychotherapy for methamphetamine use disorder and HIV risk factors. And they are now specifically looking at, can we decrease methamphetamine use? Can we improve adherence? And what happens to the high risk sexual behaviors when people undergo ketamine assisted psychotherapy? To be determined how that turns out. I do have a case presentation, but we're running short on time, and I think I would rather answer questions. And so I'm going to skip this, but my understanding is that slides will be provided to everyone, and so feel free to look through this. Thank you all for listening. Here's my email, by the way, and I do want to say here is all my references. Anyways, so what questions do you have? And again, oh, there's my email, and you can always reach out to me directly with any questions.
Great. Yes. Let's go ahead and dive right in. There are at least 20 questions in the Q&A. What does relatively common for urinary symptoms mean? How are chronic and long-term use defined? And in terms of frequency or doses recommendations for minimizing risk, are there any recommendations or is it just less is better?
Um, so I don't have a great definition for acute versus chronic. I haven't consistently seen how people define it. I do believe the difference is kind of like most people say acute is days to weeks, and chronic is once you start getting into months. How common? It depends on the frequency of use. So, urinary symptoms, you're approaching nearly universal in your heavy daily users. Um, Most people are not heavy daily users, though. And so it is unknown proportion, but somewhat proportional to how much are you using and how frequently. And I apologize. What was the third part of the question?
I think the next part was are there like a frequency or doses recommendation for risk management, or is it just less is better?
So you can look at the antidepressant literature and say if you're using ketamine twice a week, you are dramatically less likely to get the physical complications associated with long-term use. And that's just extrapolating, right? Because the rate of urinary complications, for instance, is very, very low with IV ketamine. So if you really had to nail me down, I would say using twice a week is what I would tell people. Also, 175 milligrams and below is the usual recreational dose. People get above that quickly because of the tolerance that develops fast. But if I had to say, hey, you got to use under this amount and you got to use under this frequency, I would say less than twice a week and less than 175 milligrams at a time. But I don't have a great trial to back up those numbers. That's a me interpreting the literature thing.
So I have a few clients who also people with HIV that use ketamine via snorting in the late 90s. They report using up to a bottle vial per day during party weekends. This use was monthly over 3 to 5 years. Today, they do not report any of the chronic symptoms you mentioned. We should they be concerned about any latent health issues, those being ones that may arise in the future?
Ooh, that's very interesting. I I don't have any literature to base that off of, but I honestly wouldn't anticipate it. The vast majority, minus some hepatic fibrosis, so that you can do long-term liver damage. That being said, using monthly, I'm really not sure that rises to the level of me being too terribly concerned. Even if they were using good amounts of ketamine, and a lot of the urinary stuff resolves with time as long as you can achieve abstinence.
Uh, how do the subjective experiences of connectedness with ketamine compare to psychobi psilocybin and other hallucinogens?
I'm so never done it, can't speak from personal experience, told it's very similar.
And what specific other substances should be avoided while using ketamine?
So while it is most commonly used with stimulants, I would strongly recommend you not use with stimulants and you not use with opioids. So um more stimulants than opioids, because ketamine does decrease the respiratory suppression associated with opioids. Nonetheless, it can potentiate the euphoric effects of opioids. The stimulant thing comes from ketamine and stimulants both increase blood pressure and heart rate. And so you're more likely to see cardiovascular collapse when you use both.
Are there contraindications for substance use disorder when co-occurring with other conditions such as schizophrenia, PTSD, bipolar?
Ooh, that is I could talk. This is an entire another talk. Don't use it in people with a primary psychotic disorder. Don't treat people with a primary, and by that I mean brief psychotic disorder, schizophreniform, schizoaffective, schizophrenia, just those kinds of disorders. Don't give them ketamine. It makes them worse. Um, Everything else doesn't seem to be a contraindication. There is some evidence that if someone has schizophrenia, it actually doesn't improve the substance use disorder at all and just makes them worse. But for bipolar disorder and PTSD, it seems to be okay to use, or the preliminary data says it's okay to use ketamine for the treatment of comorbid substance use disorders.
So we are short on time, and there are several questions in the chat. But Dr. Thomas, as you mentioned, participants can reach out to you and email you with their questions, your emails in your slide deck here. But I do want to highlight two questions related to HIV. So for HIV transmission and ketamine use, is there any data about transmission in booty bumps using ketamine via Vectum? And then just to highlight the other question, does ketamine interact negatively with any HIV medications that we know of?
I'll answer the first one. So the route of administration of ketamine has not been studied relative to HIV transmission. I wish I had that data, but to the extent of my knowledge, it hasn't. So I genuinely don't know. Um, and then I have not run into any evidence that you decrease the efficacy of any HIV meds when taking ketamine. Rather, it's just some HIV meds increase the duration and intensity of ketamine. And so the associated risks with using it go up. But ketamine is not going to inactivate or interfere with the HIV meds actually treating HIV.
Great, thank you. So with that said, I am gonna wrap us up only for the interest of time. Dr. Thomas, thank you so much for that insightful presentation. Again, any questions that you have, you can reach out to Dr. Thomas via his email. Ashley did add the evaluation in our chat. Once again, we will appreciate your feedback. It will be shared with Dr. Thomas. If you're on the phone, please call me, excuse me, please email me to let me know that you were on the phone and the phone number you use so that we can send you the evaluation. Our next session will be in April. And we'll send you that information in the post-webinar chat email as well. Evidence-based treatment for stimulant use disorders among populations that are at elevated risk for HIV, and that will be on Friday, April 3rd at 12 p.m. Eastern Time. So thank you, everyone, and we look forward to you joining us for the next session.
Thank you so much for having me. It's been a pleasure.
Thank you so
Thank
much,
you,
Dr.
Dr.
Thomas.
Thomas.